Hello, and thank you for inviting me to present at this wonderful workshop on DIPG and focused ultrasound. I'm here to present a sonodynamic therapy clinical trial, actually, that is designed for DIPG. And my co-author is Dr. Nagasnaya, the director of the Ivy Brain Tumor Center, because I will be presenting the first in-man clinical trial of sonodynamic therapy in glioblastoma in this presentation. This is the heme pathway. And the reason I show it is because although it's threatening biochemical pathway, it's very simple. The molecule heme is important to all of our cells because it's used in cells that simply use oxygen by creating hemoglobin and cytochromes. Its control in the body is controlled by the level of the amount of aminolevulinic acid, the first enzyme in the pathway. And the synthesis of aminolevulinic acid is controlled by the amount of heme. In the 1990s, it was discovered that the addition of excess amounts of ALA to glioma patients orally resulted in it going through the pathway toward heme very quickly, but hanging up, it was a metabolic quirk, and hanging up in the molecule protoporphyrin, the penultimate molecule in the pathway toward heme. Because so much ALA was present and they tried to rush it through the pathway to make heme, that the cells ran out of iron. So the protoporphyrin accumulation resulted in a new way to identify glioblastoma, and that's shown in this image here. The drug Gleolan is approved and used by many of you neurosurgeons out there to do just this, which is the visualization of glioblastoma through fluorescence. And that works by taking protoporphyrin on this end and shining a blue light on it. It goes to a higher energy level and then creates fluorescence, which is used as a marker here. But it's also possible to use every molecule that is fluorescing here to kill glioblastoma. And that's done by using a higher energy for a longer period of time so that protoporphyrin goes to a higher energy and then transfers that energy to molecular oxygen to create a reactive oxygen species. That can give you immediate cell death when the oxygen species dissolves the cell membrane and produces lipoperoxides, or if it activates the membrane and of the mitochondrion, it can release cytochromes and trigger apoptosis. This process is called photodynamic therapy. And photodynamic therapy has been used to treat glioblastoma at Professor Stummer clinic in Munich. This is also the clinic that developed fluorescence with ALA. And at this point in time, about 60 patients with recurrent GBM have been treated with ALA photodynamic therapy. However, this is the extremely invasive and complex procedure you need to have. And commercialization, which I tried for about a year, commercialization of this just is moot. It's not going to happen. It's one of those surgical procedures that complications vary greatly with the skill of the surgeon and the team. And you know all about those things. So how can we activate photodynamic therapy in glioblastoma without an invasive process? It turns out that ultrasound can do that. At the proper energies for microcavitation, a process called sonoluminescence occurs, where the cavitation energy is released as photonic energy and photons. And this is the actual output spectrum of sonoluminescence in water. And it is similar in tissue. Now, what you see here is a peak at about 300 nanometers and going down in intensity slightly until it gets into the blue range here. So this spectrum turns out to be ideal for the activation of protoporphyrin. And what you're seeing here in the bottom graph, this yellow line, is the absorption spectrum of the protoporphyrin molecule. And you can see it peaks at the Sorey band about 410, and this blue bar is actually the commercial blue light source, high energy blue light source that I and my team at Dusa Pharmaceuticals used to create a successful topical photodynamic therapy light source for skin precancers. So sonoluminescence is the ideal way to activate protoporphyrin photodynamic therapy. The first elegant study, I should say, done in sonodynamic therapy preclinically was done in Japan. And what you can see here is very simple. This is mouse glioma, and you could see of these MRIs, even on day 0, just as in photodynamic therapy, only the ALA plus ultrasound together creates a dent in the contrast enhancing material. High intensity focused ultrasound alone, ALA alone, and the control don't show any change at day 0. By day 3, and consider how rapid this is, by day 3, there is a considerable contrast defect here. And that contrast defect is translated into an increase in survival, as seen in this Kaplan-Meier curve for these mice. You can also see the cellular effects here in this box. You could see the control, tightly dense cells, very little apoptosis, and a very healthy proliferation index as seen by the brown cells here. At the focus of the beam, the cells are literally blown apart, and the apoptosis seen in the area around the focus. And again, very little of the proliferation index. However, about 2 or 5 millimeters away from the focus, you can see that these cells are not happy. They are simply sick. You can see a lot of edema in between the cells. You can see that there's apoptosis occurring here. And you can see that the brown in the healthy tumor is no longer there because these cells are not dividing anymore. I was able to reproduce this in Professor Kalervo Hinninen's laboratory in Toronto at Sunnybrook. And Dr. Wu, who's also speaking here, was the author of our Nature publication. What we were able to do was optimize survival in those rats with cystic glioma simply by doing multi-point sonication, which increased survival from 21 days to over 60 days. This technique of multi-point sonication simply being used by Dr. Sinai at the Ivy Brain Tumor Center in the first SDT study in glioblastoma. And in this study, the first energy dose cohort is 200 joules, the second energy dose cohort is 400 joules, and the third is 800 joules. A key part of the elegance of this study is that the sonication is applied to only 1/2 of the tumor volume. And you can see here that the sonication is indeed applied only to the posterior portion of the tumor, and the anterior portion is not targeted. And 4 days later, RGBM resection was performed. And here is the tumor was taken out en bloc, so you could identify the treated side and the control side. And what was seen was here, the SDT treated slices of tumor at the focus showed an increase in membrane disruption with 4H&E, statistically significant for the SDT side over the control side. And here is the caspase-3 stain for apoptosis, also statistically significantly and visibly different from the control side. So if you look at the first 5 patients that were treated, the disruption was consistently greater of membrane disruption in the SDT side versus the control side. And so was the apoptosis for all of those 5 patients. There was only 1 adverse event. They were minor and no major events. So we have a multi-center clinical trial in SDT 201 in DIPG patients using energy and drug dose ranging. There's positive data from Dr. Javad Nazarian's group, which will be talked about, I hope, today. And these will support our clinical trial. We had a positive pre-IND meeting with the FDA. What's remarkable, so here's simply our study, SDT-201. You can see the cohort, the Sonal-01 ALA dose in milligram per kilograms, 5, 10, and 15, and the MR-guided focused ultrasound, energy in joules, 200, 400, and 800, and that is a grid. For the first patients, we will treat 1/2 of the pontine volume at baseline, and the second half will be treated at 30 days for each cohort. That's the first patient. Primary endpoint, safety and tolerability, maximum tolerated dose, and recommended phase 2 dose. Secondary endpoints are objective response. Thank you very much for your attention.